we go. It is 8 a.m. Good morning, everybody. Welcome to Medical Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. Really excited to introduce our speaker today. Dr. Khaldoun Algerian is a clinical professor of pathology. And I was just speaking to him about the link between pathology and ethics, very fascinating, at the University of Alberta in our faculty, and adjunct professor at the John Dossiter Health Ethics Center. Dr. Algerian is a certified pathologist by the CPSA and CPSO. As well, he's a fellow of the Royal College of Physicians and the College of American Pathologists. He's currently a pathologist in the Division of Anatomical Pathology at the University of Alberta. He specializes in autopsy and has paved the pathway to his Master of Ethics at the Joint Centers of Bioethics, University of Toronto. Khaldoun speaks for the dead as one of the underprivileged human categories, and they speak for the living. So I'll hand it over to him to talk about autopsies. Thank you.
Thank you very much for allowing me to speak at the Medicine Grand Rounds. Right. This is my family. We recently moved here in last April. We're happy to be here, and definitely it's a good time to recruit people in after the winter season, I think, in Edmonton, so they don't have to. But then it'll be a surprise when they get there. Yeah. So the reason I use this term instead of autopsy is that this is not figuratively, but literally the final consultation. Unless you exhume the body, this is the final consultation for a human or medical diagnosis. So after death is our last chance without legal requirements that we can give a diagnosis regarding tissue diagnosis. So I'll go through the end-of-life goals, including, or specifically, postmortem examination, which is another term for autopsy, and what do we mean by autopsy. The second thing I'd like to talk about is consent, forensic versus clinical autopsy, which is the main goal of our talk today. Other centers may also label it as hospital autopsy, and go over some of the ethical consideration regarding consent. And then we'll go over the Alberta Precision Lab resources, helping us move together with the community. So the pathologist, the internist, and other physician and the community regarding what forms we need to fill out and how we can order an autopsy. If you follow the CanMeds or you fill out yearly the CanMeds, I've given a general idea of what goals that we will be able to accomplish today. So the first is, what is a postmortem examination or autopsy? So the autopsy, so I got this from my son that likes to read these books. And basically, like a diary, the autopsy or the body will show pathology that it has picked up throughout the years of life. So it is sort of like a diary, and to read that diary, you perform an autopsy, you take samples from the involved organs and form a report that shows the sort of like the pathology diary of that person's life. The word autopsy, I believe, it comes from the Greek word autos and opsis, which means to see with one's own eyes. So what do we see with our eyes? We see the mechanisms of disease through gross and microscopic examination of the tissue sampled at autopsy. We can confirm diagnosis that have already been established and teach it to our residents, whether they're pathology residents or off-service residents. We will be able to discover new diseases or new pathologies that either are specific to our specific occupations or specific to different regions or different categories with like pediatric, adult, geriatric, or surgery versus medical diseases. And then we can also have a better understanding of mortality and morbidity, specifically when it comes to the certificate of death that is used by public health officials to have an understanding of the epidemiology and the diseases that are affecting our community, and also to budget the health and research budgets towards the diseases that are affecting our communities directly. We're also able to teach undergraduate students and non-pathology residents to become future physicians, to continue healthcare within our societies, and obviously to train our pathologists to continue this amazing tool, although it is very historic, but it still serves a purpose with regard obtaining tissue diagnosis. So what does a pathologist do? Here I use the word authority just so that we are able to include forensic autopsy, which is done by the medical examiner's office, but they have a Fatalities Act, which allows them to choose the cases that are related to the Fatalities Act and authorize or order an autopsy. Whereas in clinical autopsy, the basis of the authorization is consent by the next of kin. And then the second thing is our safety. So we're always taking personal protective protection for before we start any incisions or examination. And then we do the reason I have history, imaging, and laboratory tests in one line. Traditionally, history is done first, and then we do physical examination in medicine, and then we order the laboratory tests. However, many of these tests are already performed, so they may be tests that we can rely on that are ante-mortem. Sometimes imaging, let's say more in forensics than in clinical autopsy, is to locate objects that may be dangerous, or it may be a requirement to identify these objects prior to go in for legal purposes, like sharpnel or pieces of a knife or bullets or such. The word physical examination, we use the word external examination in autopsy. Similarly, let's say instead of height, we use length for the body, but it is not very different than what we perform in medicine. The internal examination is the surgical examination portion of the autopsy to gain access to the main organs, the brain, the thoracic, abdominal, and pelvic organs. And then we put in a report. Preliminary report is usually 1 to 3 business days is sent out, the gross examination and an idea of the diagnosis. And then later on, a full examination is performed of all the brain and other organs, microscopic examination, and that is a final diagnosis within 60 days of the autopsy. The neuropathological portion is performed by specialized neuropathologists, and they issue a separate report. So to see with one's own eyes, so this is the thoracic and abdominal organs that are exposed, and the heart is retracted to the side, to the right side. Then we examine all the organs. We examine the weight, the measurements of all the organs. And then we take also samples. So another reason I show this is that sometimes the next of kin will have additional questions when when consent is taken about how are we examining these organs. If they ask, then you would need to have an answer. This is also available on the website, that is the APL website, and the AHS websites do have a next of kin pamphlet, but just to show that we take organs. This is not at our site, but at other sites, we're able to sample these organs for microscopic examination, and also a portion is taken for so we keep a stock just in case additional tissue is needed for microscopic examination or other tests. So this is another example of a case where there are pleural plaques. So we're not able to see the lungs or the heart because the pleural plaques have completely covered the lungs and the heart. So one of the benefits of autopsy is for worker compensation board. For people that have had exposure to asbestos. I got carried away here, just so it shows my passion and just how beautiful, I think, in my eye, some of this disease is. You can see with a pearls, Prussian blue, you can see the asbestos bodies as a beads on a string. I don't know if you can see the little string connecting the beads sort of in that, or in others. You can see in this one, it almost becomes a semicircle or circle. It is a little bit fogged by carbonaceous material. Many of them are engulfed by macrophages, and some of them distend the macrophage or make the macrophage an irregular shape. This one is seen. I've never seen this in my life before, where the asbestos body is seen, and the string is actually, so it's a transection of the asbestos body. I don't know if I'll see it again even. In another case, 57-year-old patient that was had an autopsy. She had like I think 4 or 5 years prior had a complete excision of a melanoma on the back, which was completely excised and thought to have been free of disease. When we did the autopsy, another reason I bring this up, the autopsy was delayed because of the consenting issues. So this is a form that is rarely used by the person that's requesting the autopsy. It might be used frequently by some of the physicians, but other physicians may use it once in their lifetime. And so it becomes a very awkward form to fill out with the next of kin. And so in this patient, the body was kept, I think, for over a week, and many of the changes looked like they were postmortem artifact. However, both me and Laura saw this case, and all the dark dots that we saw, and this is a portion of the heart. You could rarely find a piece of the heart that didn't have melanoma in it, this is a larger objective of the melanoma. It was in the heart, lungs, adrenals, kidneys, liver, the brain, the spleen. Yeah, so almost all the organs were involved, and they were just black dots everywhere. And on microscopy of the neuropathology and the pathology all showed that it was metastatic melanoma. But even with delayed cases, we're still able, with refrigeration and with the consent, obviously, and with refrigeration, sometimes we're able, even with delayed cases, we're able to find good tissue for diagnosis. In this other case, the lungs looked like bilateral consolidation on radiology, and was thought that this person had pneumonia initially, and they were treated in an external hospital. And by the time they arrived here, they were critical, and they passed away. And we were able to receive a consent from the attending regarding the autopsy. And you can see that it's been replaced by this multicentric mucinous type adenocarcinoma of the lung, and it typically mimics pneumonia. And you can see how the cells are in groups. You can see a signet cell here, or a signet ring cell here, and also here. Yeah. So so one of the sayings, and I think some of the morgues in Italy, they have the saying, "Death delights to help the living," is by learning from these presentations. Sometimes they're awkward presentations, or sometimes they're typical presentations, but they help us think of that the next time we have a patient. So it made maintenance of quality of patient care, to develop, modify efficacy of treatments. So treatment effect is sometimes a request. There's a part of the form for autopsy. There's an area where many of the physicians take advantage of and ask specific questions regarding specific organs, or specific treatments, or specific pathophysiology in specific diseases or organs that we can focus on. And that helps a lot the pathologist so they can answer these questions. And sometimes the questions are related to the family's request. Sometimes the family wants to ask something that is not related directly to the death or mortality, morbidity. So one of the families asked about if the patient had any breast lesions. She had left 4 daughters, and they were concerned her sister had breast cancer. And so they wanted to us to focus on that. That's not an organ we typically target if it is not part of the mortality. And so examining that also brings up another issue, which is deformity. The examination of the breast is done internally, so there are no incisions on the external of the body. So we examine it, I guess you would say, posteriorly. So from within, from above the ribs, because that's the way we dissect the thoracic cage in a Y incision of the chest. And so we'll be able to examine the breast and gross the breast internally. So there will be, once the body is released, you will not see any deformity externally. The same with the face. So open casket examination, open casket funeral is fine. It will not interfere with that. We're also able to, as I said, teach medical students, pathology residents, non-pathology residents, and also help with regard the death certificate and mortality statistics in our community. This is a sample of an Alberta death certificate. The vital statistics or registrar of death. And then this is from the Alberta Health, CPSA website, medical certificate of death example, where it has the medical cause part 1, which is a cascade of events starting from the most bottom disease going upward. I always do it on a separate piece of paper because I don't know how to think that way, and it's very difficult to do it. So, because they want the first disease that started the cascade of events at the bottom, and then, so that would be the underlying, then the intermediate, and then the immediate cause of death. So you can see 10 days and then 2 days. So that's the way it moves. So if you can fill it out directly, it's up to you. But for me, it's kind of confusing because it's backwards to me. Then the other significant causes that are not directly related to the cause of death go at the bottom. Part 2 as significant causes, but not directly related to the cause of death. The second part is of the final consultation is about the consent. And so in at the Office of the Chief Medical Examiner, they have the Fatalities Act, and they are able to authorize or order an autopsy directly, depending on the case, if it fits the act or it does not fit the act. And we have an obligation to inform them of any death that fits the act. If it does, and if it does, they can still say that we will not investigate that case. As opposed to what we're talking about today is the clinical autopsy or hospital autopsy, and this autopsy requires the next of kin to sign the form. My understanding, at least from Calgary, which is a larger clinical autopsy service, they do 3 times the number of autopsies there in a similar population. They do 3 times the number of autopsies. They receive requests from the attending physician, but also receive requests from, especially in the ICU, as my understanding, from the nursing staff that is directly related to the care of that deceased patient. And so the issue here would be getting a next of kin consent, and consent is a process that the points are available at the APL website. They have also a next of kin brochure that is in more simplistic language. And then the extent of the autopsy, as far as most of the service pathologists on autopsy, we prefer a full autopsy. However, if the next of kin have any issues regarding specific organs that they do not want to be dissected, or if they feel that they want the organs returned, we can work to have a modified autopsy as far as what organs are examined and what areas are dissected. One example would be the consent was for brain, chest, and abdomen. The pelvis was left out, but when I explained to the next of kin that the incision externally is the same for the abdomen and the pelvis, they didn't mind examination of the pelvic organs. So we talked about the ethical consideration regarding legislation and changing legislation and informed consent. Other issues include budget restraints internationally, but here in Canada, it is the clinical autopsy is a service paid for by the health system. The patient's For some reason, some of the patients ask that question. The next of kin, sorry, asked that question. There is no bill related to the autopsy itself. So one of the issues is alteration in medical education. I'll get to that next. And then retention of organs. So the retention of organs initially when I started training in the late or let's say early 2000, we were the storage of the organs were large was a sorry, the education process was given priority over organ retention. So we retained much more of the organs than we do today. So the change is huge, because we used to have in Toronto pathology rounds in the morgue, and students in small groups would come every 2 weeks to a month, would come and see the different organs from the autopsy we did the day before. And we would keep, I would say, a majority of the tissue. We would put back, I would say, 50%, and a lot of the organs were kept, especially like the major organs like the heart, the liver, the kidney, and then some of it was returned. Now, the way we practice is most of it would be returned, and a small portion would be kept for clinical diagnosis only. And that brings up the other two boxes on the consent, which is the research and education box. If possible, for the future of research and education of our students, our residents, and for research. So for health care in research, and it would be of importance if you could give time to explain that to the next of kin, that how beneficial that would be if they agree. And obviously it's their choice if they would like to agree or not, but it is beneficial for our community in general. And then timing of consent is also an issue with regard the autopsy. So a lot of the time the death occurs after midnight, occurs on the weekend, doesn't occur during regular business hours. Many of the times the person or the physician that is there is junior and this may be the first time they take a consent for autopsy. And so the issue of training our students and our residents that may not have even heard even a brief introduction such as this about autopsy becomes an issue. So if we compare like the Osler era to, let's say, the era of my teacher, Dr. Chamberlain, versus now. What happened in Osler's era would be the medical student would attend an autopsy and maybe even do an autopsy. During Chamberlain's time as a resident, even non-pathology residents would rotate and perform autopsies. And now many of the medical students and many of my friends from family medicine do not know that there is a clinical autopsy. Many of them only are educated about the medical examiner autopsies and don't realize that there's a pathway for clinical autopsy. The medical students that are rotating with me, have rotated with me in the past year, are ones that are interested in pathology and autopsy, and therefore they are rotating with me. But from my experience with them, they have never had anyone talk about autopsy during their medical, their 4 years of medical school. So it brings us to the final part of our presentation, which is how do we move forward? So how does does the hospital plus the pathologist and the community move forward? And what are the resources that we can use regarding regarding our future in obtaining more information about autopsy, or directly for the next of kin. So a brochure for the next of kin is available at the Alberta Precision Laboratory website. We have the adult autopsy information for physicians, how to go through each part of the consent and the forms, and what are the numbers to contact, and then also the forms themselves are at that website. So within Canada and locally, we do talk about we do have information available to us through Alberta Health, the College of Physicians and Surgeons of Alberta, and many federal agencies regarding consent, and that how consent is established, also about the autopsy and about the rights of persons in Canada. As far as the websites so I'm guessing this probably would it show, but if I bring it to the next screen, I think it will, right? Am I able to do that? So that will that show online? Yeah. It'll show online. So the Alberta Precision Laboratory website shows a brochure that can be printed and handed out, or can be seen online for the next of kin, about what is an autopsy, what is consent, why perform an autopsy, common questions and answers, including there being no charge for autopsies. So that's a frequent question that we have to go through. And then this is for physicians and how to go through the consent for autopsy, who acts as a next of kin. If it's a phone consent, then there should be two witnesses from that is listening to the phone call from the attending side, not from the family side. So the witnesses are from our side, the healthcare side. And there should be two of them, but if it's in person, only one is enough. And then identification of the bodies. Usually this is not an issue with hospital deaths because they're already identified. This should be, yes, so this is where any technical information, if needed, whether the form for the consent is there. So this is any restrictions. Hopefully there's none, but if there is, because many people have cultural issues that may or may not be resolved by discussion with the family about there being no deformity to the body. And then also the medical education and research boxes are there. And then here's where any specific problems are needed regarding the autopsy. So this is just to prepare you for any feelings you might have or not have about the next slide. So my purpose for this is for the autopsy itself and not for anything else. So we want to make the autopsy great again. It's not fair that Calgary is like 3 times the numbers that we have. I think that we should speak on behalf of the living more as they are, or at least not get worse than what we are now. I think that is the main goal, just to be steady. If we can get better, I think that would be a great thing, but definitely not to go backwards, which would be a terrible thing. So I think that what's happening now is we're not communicating well. So the physicians are thinking on their own, and they understand from their perspective what an autopsy is. So physicians have an idea, and then the pathologists also have their own idea about what an autopsy is, and then the public has an idea of what the autopsy is. But we're not interacting in a way that we understand each other's perspective or each other's restrictions or difficulties. Many of the difficulties we're solving in our SIG for Alberta Autopsy is by fixing some of the difficulties some of the physicians have brought up regarding the consent form and how it looks and the layout. So we're changing that. And at the same time, we're working to get it electronic or like online or so how do we move forward? So as I said that, in Calgary, they have 3 times the autopsy numbers. They have mortality morbidity rounds. They have education in medical school about autopsy. And a US study, multi-center study of pediatric hospitals, they found that when they had a specialized department within admissions called Decedent Affairs Office, that they had a better understanding of all the process and flow of the request of autopsy or organ donation or anything else that is related to the postmortem period. And they found that very beneficial. In Calgary, they do have the Vital Statistics Office that helps them with that. Here, we're working on that also. And a university study in Texas, they also had a similar idea, and they did use a Decedent Affairs Office, but they did also good communication with the physicians to make sure the physicians understand the pathologist's perspective and the pathologists understand the physician's perspective or non-pathologist physician perspective about what an autopsy is. They also did specialization, which we have here actually in Edmonton, and we're doing very well with that. So the brain and spinal, so the central nervous system is examined by examined by neuropathologists, and the autopsies are performed by pathologists that are interested in autopsy. And not all pathologists are performing. So the pathologists that opt out are opting out of doing autopsy. So only the ones interested in the autopsy are doing it. Most of us don't have a problem to communicate directly with the family if needed, or to discuss. And there is a phone number on call for pathology if needed. And you can discuss at any time with the on-call regarding that. But usually the forms are, once they're filled out, it will just be an automatic process. Also, turnaround times. So our turnaround times are within the standard set by CAP. So within 3 working days, we have the preliminary, and then we have the final report, including the micro and the neuropathology, which is usually signed out even earlier than that, within 60 days. And then in Yale, they, similar to what they did in Texas, they did a quality improvement program, basically looking into the standardizing the autopsy and basically good communication and rounds with the non-pathology physicians that were ordering the autopsy, so that the results were discussed and everybody feels comfortable with the quality of the service provided. A Michigan study also used the Office of Decedent Affairs, but what they did a little bit differently that I thought was interesting, that the admin there were social work, either specialized in social work, or they were trained in social work principles, and they had clinical training regarding what processes need to be looked at and what legal forms need to be looked into during death. So that assisted the physicians to finish that part of the flow of ordering the autopsy. Because many of the difficulties with internationally was the form itself, getting the form signed out. And then in UK, they had improvement of facilities. UK is a different level, in my opinion, especially in England. I found the level that they have there is just amazing, especially for clinical autopsy. Is at a completely different level what they're working with, the facilities, the curriculum in medical school and residency, and specialized or inspiring instructors that are interested in the autopsy. In Brazil also, they had the pathologist helping with filling the death certificate with the registrar of death. So a review which would help the statistics regarding mortality statistics within Alberta, let's say, but they're obviously within Brazil. So the path forward would be pathology needs to do specialization, which we're already doing, standardization, which we are. Quality control is something that is the whole process of standardization, specialization, but also it would be better if we had rounds to discuss the results, not from our point of view, but from the physicians that are requesting the autopsy point of view. Is that what they are looking for? And then the turnaround time, as I said, is the CAP standard, with the College of American Pathologists standard. We need to pass on the knowledge to the students, to the non-pathology residents and other staff, whether they are non-autopsy pathologists and non-pathologist staff, so internal medicine, surgery, education of the public and public relations, offices of Descendant Affairs, or whatever you want to call it. But in the end, there needs to be a process for the consent to be valid, and we need to know some knowledge so that when we talk to the public, so the next of kin, we need to be able to help them understand what the autopsy is. A lot of the limitations when I get a limited autopsy and I talk to the next of kin, I explain to them what the autopsy is. They, I would say, I've not failed any time to explain to them that it is not going to delay any more than a limited autopsy, and it will not cause any deformity to the body. And I've had so far 100%, success with that explanation for the families. And then the other issues, litigation issues. Some physicians ask about that. The studies in the States show that litigation is, especially because the autopsy is requested and there's closure and there's sharing of information and education of the next of kin, litigation actually decreases in cases that a clinical autopsy was performed. So we're talking about clinical autopsy. So that's what we're trying to find a common ground between non-pathology physicians, pathologists, and the public, so that we're all on the same page. And I think that's the best proposed path forward for improving autopsy. The other thing is, this is getting you ready for if you feel or you're sensitive about Edmonton. I saw a haunted house here in Edmonton. They used I think it's called Deadmonton, and I think that if we own this label, but we use it because we speak for the dead and not because it is a slur or something that someone in Calgary would say. So it brings me to the end of some of the questions that I thought some people would ask, and the answers are there. The cost, there is none. We went over some of that. Legal issues, usually decreased litigation and closure to the family. There's no deformity to the body. Cultural issues, we're flexible. We can move faster. We can we can store the organs for lesser time. We've done cases where all organs, including hair, and is returned to the body within 1 day. I've done an autopsy like that before. Limited versus complete, we talked about. The autopsies it's not extra work. We specialize in autopsy because we love autopsy. So don't feel this is a burden on us. Some physicians feel that if they're requesting a complete autopsy, it's a burden. It's not. Actually, limited autopsy is actually, to me, more difficult because it limits your ability to give or put all the knowledge together. It's beneficial for research and teaching. Turnaround time, we also labeled that. And my last message is, why not speak on behalf of the dead and own Edmonton or Dedmonton in that fund? And that's all. Thank you so much.
So, I mean, I think this is sort of a start of where you're trying to go with regards to education and just reminding us all that this is a service that's available. And I have to say that my personal experience in the past, it was very difficult in terms of turnaround times. So you guys have definitely done some quality improvement from that perspective. And I just had a question with regards to penetration. Like, have you had the ability, because most of our divisional subspecialties have morbidity and mortality rounds, and it seems to me that's a natural place to embed the pathologist, whether it's limited pathology or the full autopsy. So is that happening in any area in particular that we can use as a model at this site, or?
I think the neuropathology presents to neurology rounds some of the autopsy findings.
Yeah, it's not like a morbidity and mortality round.
Yeah, okay.
So it's more like a case round sort of idea.
Yeah. So there is an area where that's happening. I think Chris wanted to say add to that.
I just want to say that actually we're very fortunate. I'm glad to see all three of our neuropathologists are here, and they are fantastic at enabling autopsies. But I'd like to make a second point just to emphasize how important autopsies are for research. And I think Frank and I will attest to the fact that we've actually discovered new diseases. And I don't think MR and liquid analysis and even biopsies are sufficient. We still learn a lot in the autopsy room. I like to call it the temple of truth, because it's really imperative for research. And I can't emphasize that enough. And I think everybody here from neurosciences would agree, right? Wendy, Richard, as well as Laura and Frank and Sumit, right? Yeah, it's absolutely essential.
Yeah, I don't know if you want to repeat those comments and
Sure.
maybe comment on any of that.
Yeah, so it's very important for that part of the so that's one of the issues we do have to deal with, and it would be essential when filling out this autopsy form. Many of the times they just tick this box, which is a shame. I've never talked to a family about the consent and explained to them the importance of this, and say no. They've never said no. So I think if we're able to take time, obviously it's their choice. They can say no, this is a clinical autopsy. But if we take the time to explain to them how important it is for our medical students, for our residents, and for research, I think in my experience, 100% of the families have agreed. And so it's box number 4 right now in the autopsy consent.
Sanjay.
Yeah, I just want to follow up on what Chris said. So, first of all, some clinical management, education, research, this is really, really important. So I'm really excited about these rounds. And also very happy as well as the neuropathology, very supportive. So over the years, we've been able to build actually ALS brain bank. That's facilitating the project. Just been fantastic. I think it's also that, how do we actually ask the questions? Where to ask the questions? Applications, right? And then, most of these pathologists that work fire, it's coming through clinics.
The audio is dropped off.
Yeah, it has. I was gonna say something. I didn't want to interrupt Sanjay. Just if you can speak up a little bit.
Sure. So then, how do we actually make this happen on the boards? I think that's where this is really good. Down to exercise, the medical students, the trainees, they're the ones that really are front lines. Their messaging is really important. So, I have to say that when I'm on service, it's not something we talk about, but I think we should be. Yeah, really should be. So I'm glad to hear there's infrastructure and resources that we can ramp this up. We really have to work.
Ashley, can you just check on that audio? Do you mind repeating what Sanjay meant? Or do you
Sure,
want me
I
to
can-
just,
I can,
yeah,
yeah.
to summarize?
So so my, what I understood was that we need to emphasize the, where's that box? Oh, it's gone.
Well, just the conversation.
Yeah,
how to
the conversation.
facilitate those
Well, yeah,
conversations.
exactly. So in my opinion, and from what I presented is what we need to target our medical students. I have to find a way to find someone that is within education and ask who's educating the students on organ donation, end-of-life decisions, breaking bad news of death, and getting them to add one line about autopsy on their presentation. Or if they can invite me, I'm definitely on board. I need to find a way, just like the neuropathologists were successful to have rounds with their neurology colleagues. I would be interested in presenting in different divisions, whether it is a case, whether it is about autopsy, whether it is about like the ethical issues or the consent form or specific cases. And then also the other thing is once we have that established, we can also target the residents also. So I can talk directly if invited to the residents. It doesn't have to be a clinical round. It can be a pure educational round for the non-path residents. We do have medical students that rotate and regularly off-service radiology does attend autopsy. I've never seen anyone else. So medical students and off-service radiology residents, they said it was beneficial. The other thing is clinically, the families can always ask any question here and we can put it in the report, but still, just like this round, I really appreciate that it is live. I can see your faces, I can understand your body language. And so the form is not the best way for me, but it is a legal form that we can use to communicate. But I think the best way would be your divisions, your rounds, a phone call. I can talk to your residents, your medical students, whether it is pure academic like this, like an academic presentation, or it is a clinical case or a list of cases. I have a lot of ideas, even just being here for just 1 year. The amount of malignancies I've seen, most of the autopsies I've dealt with in other institutes don't have this. But this is also the first time I've worked in a centralized hub for clinical autopsy. Most of the other hospitals that I've worked at were institute-based. So like St. Mike's, they only did St. Mike's autopsies, Mount Sinai the same, UHN the same, and so on and so forth. Here, I find it is an amazing idea that they have all the autopsies in the North Zone in Edmonton.
So we need to go outside the university site as well, is what you're saying.
Yeah, I should.
yeah,
Yeah,
in terms
definitely.
of-
Yeah.
Wendy?
Hi, boss. There's a preponderance of neurosciences present here. And I think that reflects that the father of neuroscience, Charcot, his shtick, his raison d'etre to some extent was clinical pathologic correlation. such that there's an anecdote, and I'm not sure if it's true, that he actually hired someone who had an interesting neurologic presentation to work as a cleaner so that he would have access to her when she died. I don't know if that's true, but that's a story they tell in neurology. So that pertains to issue in neurology. We see interesting patients, and we had a discussion in clinic yesterday about someone who had an interesting presentation, but we don't have the resources to follow everyone. So the issue of pre-consent, normalizing the final consultation. And thank you for that language, because that is a nice introduction. When the resident said yesterday, I don't know how to start, that is a nice introduction. The final consultation. When we return someone to their primary care doctor, who nonetheless is someone who neurologically is of interest, issues arise, which is to have a family. The family can be very invested. I pre-consented someone 2 years before he died. Not officially, but the family was very interested, notified us when he died, and we obtained the autopsy, and it was a case report. So it was very academically interesting. But having an office that assisted us, having something that would allow us to say, here's someone we want to track, the family's committed, but we don't want them to be running into roadblocks and problems when the final consultation arises. So that's a really interesting idea for me. And furthermore, we do need to work on communication. There's a real concern on the part of the clinical side that we don't want to prolong suffering. We don't want to add to suffering. And so finding the language to support the clinicians and the families to say that this doesn't prolong suffering, it actually addresses suffering, and using, terms like closure and finding the language to say this is actually a way of allowing the family to have closure, to have an understanding of the final illness or the lifetime of illness is part of communication. I appreciate that you would like to bring this to end-of-life discussions. And so I think that's a great idea.
I think it's too bad that the folks at home didn't get to hear your comments. Really great comments. I agree. The language was very helpful here. I don't know if you want to comment any further or.
Well, yeah, I mean, this comment and all the other comments is for me, I have like tears of happiness. They just dry up because Edmonton is so dry, so you cannot see them. But in reality, like, this is my true passion is autopsy. And I think that our side, the AP side, we need to live up to the neuropathology expertise and give that same message that we're available, we're here, we're willing to give academic lectures. And I think that's a good idea also, where you said it's like a pre-consent sort of idea that there's a family that we can, or there's a, I'm not sure how to start that. I've not seen that before, like where we like sort of have them labeled already ready for that. But I agree that we could talk within our department to see how we can facilitate or help that, or do something similar to Calgary, like the Vital Statistics Office.
Well, there's a lot of interest that's been stimulated. And yes, we need to include other organs besides the brain as well. So we've learned that here, right? What we'll do is we'll try and address all the questions online. We'll send them to you, if you don't mind.
Yes,
and then you can address those. And of course, you're here right now if there's any other questions directly. But on behalf of the department, I'd really like to thank you for getting the conversation started. We think this is really important, and we'll keep working on how we can continue to grow this area. So thank you.
Thank you so much. Thank you, everyone.